Good evening, everybody. So, we'll start with this today, multiple sclerosis. I am going to take up the challenges which we face in the diagnosis, focusing on the recent criteria which have been published, and Darshan is going to take about the treatment changes which are happening. Multiple sclerosis is an enigma. There are many issues. Whenever we see a patient, we suspect multiple sclerosis in a lot of patients, but we are never sure. So the first challenge is there is no good biomarkers. The first biomarker which came was oligonucleotide band. So that was the first biomarker with relatively good specificity and sensitivity. After that, few more biomarkers have come up, which we'll discuss. And second point is misdiagnosis. So 15% of cases are misdiagnosed, and the common is migraine. So that was published in, I think, 2014 Green Journal, that about after 100 cases which are wrongly diagnosed, about 30% were migraine. And that was mainly based on the MRI, white matter changes in the MRI. So those patients who had interferon, they had a migraine with MRI changes and wrongly treated as MS. Then certain vascular disease, especially elderly people, you may get white matter changes, you are not sure. Patient may have typical symptoms but maybe connective tissue disorders. So it looks like MS, clinical symptoms, MRI, but they may be connective tissue disorders. More antibody, especially in pediatric. You may have disease, look at the demyelination disease, that may be recurrence in first 3 months or later on, but more antibody may be there. Underdiagnosis is also a major issue. Second other issue is clinical isolated syndrome and radiological isolated syndrome. By clinical isolated syndrome, we mean that patients who don't fulfill the criteria for MS. You get a typical attack, MRI is suggestive of MS, but you don't fulfill the criteria for the MS. So that's clinical isolated syndrome. And radiological isolated syndrome, you get the MRI changes of MS, but no clinical symptoms. So that's another syndrome. So what to do in those cases? Whether to start treatment or not, in clinical isolated syndrome or radiological isolated syndrome, how can you diagnose that? If you diagnose MS in again same asymptomatic patients or without typical symptoms, patient may be presented with trigeminal neuralgia, paresthesias, without typical attack. By attack we define as focal deficit, which have been seen on clinical examination lasting more than 24 hours. So that is the definition of typical attack. So patient may have some transient weakness, patient may have some trigeminal neuralgia like pain or transient symptoms that don't fit in our typical attack. But you may get MRI suggestive of MS. What to do on those patients? Then another point which is coming up nowadays, that we classify MS as RRMS, secondary progressive MS, primary progressive MS. Nowadays it suggests that they are part of same pathological spectrum. It's a balance between the inflammation and neurodegeneration. I think Darshan will take more about that. But they are basically same disease. Basically depending on what is prominent. If inflammation is prominent, we get relapsing form. If degeneration is prominent, we get the progressive form. So they are the same disease depending on what is the prominent pathophysiology playing a role. So we'll start with Charcot, and you can see what here described. So here it says the diagnosis was clinical based on episodes separating time and involvement of multiple CNS area. So ataxia, tremor, nystagmus, dysarthria, that are all taken as a signs of MS. So he said that triad, if you get this, you can suspect MS. So that was the first crude but still very relevant. First formal criteria was by Shoemaker in 1965. Here we get what this shows as dissemination space and time. So multifocal CNS lesion, that is dissemination in space. And then 2 episodes. And he gave the age, 10 to 50 years. And no other diagnosis. So that's very important. MS is a diagnosis of exclusion. Always keep that in mind. So MS, there is no definite criteria. So always keep in that we have to rule out other disease. So any patients with MS who comes in follow-up, always keep a watch out whether we are missing out any other diagnosis or not. After that, they came the Poser criteria. In that change was that laboratory was introduced. So as I said, in that there was oligonucleotide band and EO potential. So Poser gave the first clinical definite MS as well as laboratory supported. So first was by Charcot, the Shoemaker formalized that, dissemination space and time, and he gave some sort of criteria. Poser introduced the laboratory criteria. And after that we are all aware of this McDonald's criteria. So if you see this history, it's small, but I'll just take the highlights. 2000, 2005, 2010, then 2017, and latest is 24 or 25. So these are the 5 McDonald criteria which have been published, and with that gives the change how our understanding of the disease is changing. So if you see this initial criteria, so here if you see dissemination space, 3 of the 4, either one gadolinium enhancing or 9 lesions. So that's one criteria. 1 infratentorial, 1 subcortical, and 3 periventricular lesions. So you see dissemination space was that strict. After that, in first revision, almost same was there. In 2005, dissemination space. In time there was some change, but in 2010 they simplified it. They gave 4 regions. So if you get any 2 regions after 4, you can say dissemination space. So they are much simplified in 2010. So they had given the 4 regions: periventricular, juxtacortical or subcortical, cortical, infratentorial, and the spinal cord. These are the 4 regions. So dissemination space in 2010 was any 2 regions out of the 4. History gives a clue how the diagnosis has evolved and how the changes happen. So just I will spend a few slides for that. Dissemination time also, if you see, this was the criteria which used. Maybe Mayank Bhai, Bhatia, me are aware of this initial McDonald criteria because we were doing DM at that time. So when this criteria came, so if you see this, more than 3 months. So gadolinium enhancing lesion 3 months after, or new lesion 3 months after. So they kept a gap of 3 months. In 2005, for gadolinium enhancement 3 months, but new lesion after 30 days. So only one change in MRI. Dissemination space was same. In time after 30 days. In 2010, they made it much more simple. Any new lesion, any gadolinium enhancing lesion in any scan, you only do no time period. So in the next scan, if you get a new lesion or gadolinium enhancement, you can say dissemination time. Another thing, the single MRI, if you get enhancing and non-enhancing lesion, dissemination time. So this criteria simplified the things. 2010 MRI criteria. Before that, it was much complicated. 2010 criteria were much simple. So MS diagnosed because of the therapeutics available. They felt we should diagnose more patients. The always caveat is in all this exclusion. We have to keep that in mind. So MS is diagnosed by dissemination space, dissemination time, and third point is exclusion. Exclusion of other disease. So never just dissemination space and time. Third point is equally important. We have to exclude other disease. So this is the 2017 diagnosis. After that we will go to the latest. So here, this is simple. If you get 2 attacks and you get objective clinical evidence of 2 lesions, like you get a patient with optic neuritis, you examine that patient recovers. After a gap of 1 month, anytime he develops myelitis or ataxia, you examine that patient. Then that's definite MS. 2 episodes which you objectively examine with a gap of 30 days. So disseminate space and time is done until you have to just see for exclusion of other disease. Otherwise this criteria are fulfilled. So if you have only 2 attacks but clinical evidence of 1 lesion, like patient may have a past history of vision loss, but you are not examining that, you don't have evidence. When the patient comes to you, patient may have past history of ataxia or numbness or some heavy sensory loss or something like that, but you are not examining at that time. So history of 2 attacks but clinical evidence of only 1. So dissemination in time is there because of 2 attacks. Space is not there. So you require criteria for dissemination in space. Again very simple. Any 2 of the 4. Either you get a second attack to demonstrate dissemination space, or you any 2 of the 4. You can say dissemination space. So same criteria have been used. Then in this 1 attack, so patient comes to you with myelitis. You do a VEP and you get prolonged nerve. So that is 1 attack with evidence of 2 lesions. So dissemination space is there, time is not there. So you have to give for time. So for time, either you get a second attack, or you get enhancing non-enhancing lesion, or you get a new lesion after some time, or enhancing lesion after some time. And another new thing in this besides 2010 was CSF follicular bands. So CSF follicular band was taken as a in place of dissemination time. Yes, if follicular band is positive, it indicates a chronic disease. So you don't require to demonstrate dissemination in time. So if you even get a single attack with past history of, maybe you get objective evidence of dissemination space, like in MRI or lab investigation, if you have dissemination in space, for dissemination time, even auricular band will do, enhancing non-enhancing lesion will do, or any new lesion will do. So they have simplified that, dissemination space and time. Here only one attack, you have to demonstrate both, dissemination space and dissemination time. Progressive, the criteria were that any 1 year disability progression with 2 of these, more than 1 brain lesion, more than 2 spinal cord lesion, and CSF and auricular band, any 2 of the 3. So more than 1 brain lesion, more than or equal to 2 spinal cord lesion, and CSF auricular band. So any 2 of the 3 for progressive. So these were the old criteria. Just I will take the MRI of all these findings just to discuss. And in this 2017 they had said that cortical, juxtacortical can be taken together, because they say it's very difficult to differentiate. So in 2017 other change was that they removed the word subcortical. They said juxtacortical and cortical are difficult to differentiate, you can take together for the 4 regions. So we can see here, this is classical periventricle, you can see. This is the cortical or juxtacortical lesion. Here you can see this is optic neuritis. This is brainstem, spinal infratentorial. Here you can see in the spinal cord, partial spinal cord lesion is seen. And these two we will discuss. These are the new things which are included in criteria. Anybody like to say what is the first one?
Central vein side.
Second is central vein side. First, paramegaly rim lesion. So these are the new things which have been included. Paramegaly rim lesions and central vein sign. So these are the new 2 things which have been taken in the criteria, which are again biomarker for MS. So we'll go into this. After एक detail में लेवाना चाहिए, no need to go for this. We'll take one by one. So first was radiological isolated syndrome. So always there was controversy. You get patients with, you get an MRI done for non-specific clinical condition. You get an MRI suggestive of MS. What to do? Whether to treat or not to treat. How to diagnose MS. So for that, they have given something like, what is the typical clinical history? You will be surprised to see this. So 2 years 20%, 5 years 35%, 10 years 15%, and 15 years 72%. So if you get a classical radiological isolated syndrome, these patients will develop MS. So you have to treat. So how to diagnose patient with radiologically isolated syndrome? For that they have a criteria, because they said if you follow these patients over time, they are going to develop MS. So 50% over 10 years and 72% over 15 years, pretty high figure. So, as I said, radiological isolated syndrome, you get the MRI lesion without any typical symptomology. By typical symptomology, we know that white matter deficits lasting more than 24 hours, ataxia, vision loss, weakness, or paraparesis or hemiparesis, but deficit should be more than 24 hours, or MLF or something like that, diplopia. So typical white matter lesion lasting more than 24 hours. If you don't get that, it's atypical. A patient will be asymptomatic. For that, you can't say this is typical MS. So if you get RIS, if you fulfill DIS and DCT, DIS and DIT, you can say it's MS. So you can see MRI lesion with more than 2 topography, then it's MS. If you can demonstrate enhancing non-enhancing lesion, if you can demonstrate new lesion, then also it's MS. So with radiological isolated syndrome also, you can put the possibility of MS. Second thing is, you get the dissemination space. For time you can get the auricular band. So if you get the dissemination space and you get the auricular band positive in CSF, it's MS. So you have to treat as MS. In patients with RIS fulfilled dissemination space, more than 6 central venous signs. We'll take that in detail later on. What is central venous sign? So if you, these are the 3 things they have said. For RIS, if you get dissemination space and time, if you get auricular dissemination space with auricular band, or dissemination space with more than 6 central venous signs. All these are suggestive of MS. So you can diagnose MS in RIS. So in RIS also always keep this in mind. You have to suspect and you can put a diagnosis of MS. So these are the few more things. They have taken optic nerve as a 5th topography, because we are taking brain, infratentorial, spinal cord, and cortical, periventricular and subcortical. They have added 5th. Optic nerve lesions may be taken as a 5th topography. DIT is no longer needed. If DIT is there, it's good. They have given a lot of options in place of DIT, and they have given the reasons why DIT should not be compulsory. It's not you can use DIT, but if you don't go to DIT, you can diagnose MS without dissemination in time, and they have given criteria for that. Updated DIS criteria. They have changed the DIS criteria, so they have given new suggestions in DIS criteria, where you can diagnose MS without dissemination in time also. And kappa free light chains may be used in CSF. So that's a new innovation. Same as auricular band. And same criteria for PPMS and RMS. They say it's the same disease. Basically, it's a continuum of the same pathophysiology. So they are the same disease. So you have same criteria. Here you can see the optic enrollment is ranging from 70 to 100%. Various studies they have quoted in this paper and other references. So optic nerve may be taken as one of the 2 of the 5. So initially there are 4 topography: periventricular, cortical or juxtacortical, spinal cord, infratentricular. Optic nerve is 5th. So any 2 of 5. Initially it was 2 of 4 in 2017 till. In 2024 they have said 2 of 5. So any 2 of these 5 topographic dissemination in space criteria fulfilled. And how you can demonstrate optic nerve? Classical is MRI. You can demonstrate MRI. There should not be perineuritis. There should not be typical chiasmal enhancement or long segment lesion, which are more in NOSD or MOG or perineuritis in MOG. So if you get typical lesion suggestive of short segment lesion, which is typical of MS, you can use that as MRI is enough to say the optic enrollment. You can use VEP or OCT also. So asymptomatic patient, you have OCT or can be used, or VEP can also be used to say there is optic enrollment. So for 5th topography, MRI, VEP or OCT can be used to say there are dissemination in space. So you can use that to fulfill the criteria for dissemination in space. That was one thing. DIT is no longer required. Here they said that these are the studies which had included CIS, clinical isolated syndrome. Usually DIT will not be there, because if you get dissemination space and time, it's MS. So clinical isolated syndrome, they took the time required to develop dissemination in time, and they said it takes a long time for the treatment and placebo. So you delay the treatment. So dissemination time should not be compulsory. So they will revise this criteria. So you can diagnose dissemination space, I said 2 of 5. So dissemination space, one change is 2 of 5. Another important change is, if you get 4 of 5, that's enough to say it's MS. You don't require anything else. Very drastic changes. So if you get lesions in 4 area of 5 topography, it's MS. Nothing else is required. So, pachi presence of 6. If you get 1 topography, only 1 area lesion, then you can use this 6 central venous sign or ring lesions plus DIT or CSF positive. So CSF positive in place of DIT, ring lesions or DIT or central venous sign can be used for this. And for progressive lesions, 2 spinal cord lesion can be used. So DIT, they said it's not compulsory. Distance, space and time is fine. But even with 1 topography, you can diagnose MS with, if you get this. Or even with 4 topography, you don't require anything else. So that are the changes in dissemination space and time which they have suggested. So another is use of kappa free chain. So here they have shown that if you see sensitivity and specificity of positive predictive value of both are almost same. Kappa positive predictive value and negative predictive value, or sensitivity specificity, both kappa free light chain or auricular band. IgG synthesis or IgG index are less sensitive. So IgG index should not be that much used. It's less sensitive. So positive predictive value, this is specificity is also less, and sensitivity is also less. So this says either use auricular band or kappa free light chain in place of that. Any one of the 2 can substitute for dissemination in time. So paraclinical test, anything such as OCB and substitute for OCB. So for dissemination time, you can either use auricular band or kappa free lambda chain. Primary progressive MS, they have shared that any progression over 12 months and more than 2 spinal cord lesion plus CSF positivity is enough. So you can use that for diagnosing for this PPMS. And another new change is, as I said, paraclinical evidence, one is kappa field abduction, then central venous sign, and these ring lesions. We will discuss both of them, paramagnetic ring lesions. So, as you are all aware, MS is a disease of perivenular inflammation. We all know that the demyelination occurs in the perivenular region. So, this is the classically, you see the venule, demyelinating plaque, you see the inflammation around the venule. And you can see here in the pathology also, this is a cut section. Here there is some inflammation around the venule. And this is again marked out over here. So acute lesion you will get more inflammation, chronic lesion you will see this thrombosed vein with something like this. So if you see more specifically in SWV3T, you will get some sort of this type of central vein sign. So central vein sign may be a feature of MS. It's not 100% specific. It can be present in other disease also, but it can be feature of MS. So what are the criteria when to say it's a central vein sign? So they have proposed, these are the North Atlantic Imaging MRI Society criteria, which they have proposed, which are used right now. So it's a line or a small dot. So if you see this if you cut as a sagittal or coronal, this will be a dot. So either it can be a line or a dot, depending how you cut the plaque. Then it should be at least 2 planes, and as a line in at least 1 plane. So if you just get in 1 plane, it's not sufficient. So if you get a line in 1 plane, you should get a dot in another plane. So if you get a line in coronal, then axial or sagittal, you should get a dot. So you should get both a line and a dot. Then vein diameter should be small, less than 2 millimeter. It should run almost throughout the lesion and should be central. So you see, this is almost throughout the lesion and almost central. So it should be a line or a dot almost throughout the lesion and should be central. So these are the, then you can say this is a central vein, because, and you have to ask the radiologist to look for that. Radiologists don't look. So they don't see for central vein sign. 3 Tesla SW image, they have to look for this central vein sign, and you need all the cuts, axial and coronal also. So diagnostic performance, so if you get 3, then sensitivity is 81%, with specificity is 64. But if you get 6 central vein sign, specificity is 93%. So central vein sign may be present in other disease, but the number is usually less. So they have said select 6 should be used. So if you get, that's why you see everywhere it's 6. So if you get 6 central vein sign, specificity goes very so more central vein sign. You can say this is MS. So that's why they have suggested this 6. So select 6 has been used. And this is comparison to auricular band. It is almost as good as auricular band. So it's another biomarker. So kappa field light chain is new biomarker. Central vein sign, especially if you get more than 6, again good biomarker with good specificity. You can use that. Here is an example. You can see axial, coronal and a sagittal. You can see this is the central vein, right? And just one, sorry. What are the exclusion? If the lesion is less than 3 diameter, so very small, 3 millimeter, very small lesion, don't take that lesion. Lesion has to be a large one. Confluent lesion you should not take. It should be isolated lesion. So if you get confluent lesion, don't see for central vein in that. If you get multiple veins, it's not right. So poorly visible, multiple vein, very small lesion or confluent lesion should not be taken. They should be isolated for central vein sign. So these are the criteria they are given for central vein sign. And here we can see this example. You can see this is a single lesion, vein running right through the lesion. You can see a dot in the sagittal. Again here you can see this dot. So these are the, say the size has to be more than 3 millimeter. So if you see there is no central vein in this. Here there is central vein but size is more than 2.5. Here you can see there are multiple veins. These are confluent lesions. So you can't take small size, less than 2.5 millimeter, confluent lesions or multiple veins. They should not be taken. So this is the classical what we should take. Lesion more than 3 millimeter, central vein running throughout the lesion, seen in more than 2 sections as a line as well as a dot. If you get that, that's central vein. So don't take these type of small lesions, confluent or multiple veins. They should be taken as a central vein sign. If you get more than 6 of this is central vein sign. So this is a new biomarker which has come up and which is used widely now. So demonstration central vein may be used and can increase specificity, is not required for diagnosis, and patient with typical symptoms and DIS, the presence of 6 central veins, and do not require DIT. So if you get typical symptoms, more than 2 topography out of 5, and you get 6 central vein, DIT is not required. And if 1 topography, you require 6 central vein sign plus DIT or CSF. So you only 1 topography with central vein signs or parametric rim lesion, you require DIT. If you get 2 topography or more, you can say just this is with central vein sign, you can say MS. DIT is not required. Otherwise you require DIT or CSF. This is another paramagnetic rim lesion. As a central vein sign is due to the perimedullary inflammation. Paramagnetic rim lesions are due to the microglia or the macrophages. So if you see the pathophysiology of the MS, initially in acute phase there will be acute lesions which are known as active inflammatory lesions. In that mainly there is inflammatory response around the vein, and here the blood-brain barrier will be broken down. There will be contrast enhancement. But if you go to progressive phase, it's called as chronic active lesions or slowly expanding lesions. That's what you will get. These lesions are progressive. Here the blood-brain barrier is intact, so the drugs don't work. You require drug with good CSF penetration for progressive disease. And here the microglia plays an important role along with B cells. So the pathophysiology for the progressive lesion changes. So any patient predominantly may have initial inflammatory, may go to the progressive phase. So this is a sign of a neurodegeneration. You get a microglia, you get hemosiderin ring. So if you see this is the hemosiderin ring. Okay, it is not seen in other. So this is highly sensitive and specific. You can see this. Sensitivity is low, but specificity is very high. So a single paramagnetic lesion, there says specificity is of 99. So if you get more than 2, it's MS. So highly specific, sign of microglial process and sign of the neurodegeneration, the iron deposition. So that will show this paramagnetic rim lesions typical. It will not seen in the systemic vasculitis. In fact, other diseases it will not be seen. So this paramagnetic rim lesion is very specific. It's a sign of a progressive disease. It will not be seen in the acute phase or acute relapsing phase. This is a sign of a, when you get this disease, slowly expanding white matter disease or paramagnetic rim, you can say this is a progressive disease. This is not a relapsing remitting disease. So you can say from MRI how the things are changing. Typical RRMS you will get the active lesions which are enhancing and which are 3 mm, 4, 5 mm lesions. But if you get this type of diffuse changes with paramagnetic rim, it's a progressive disease. So that can give you, just MRI can give you a clue what we are looking into, what are the disease process going on. So these are the few things which have come up which are changing the way the MS treatment is being approached. So demonstration of PRL may be used in diagnosis, increase the specificity, not required because in RRMS or acute phase MS, these paramagnetic lesions may not be present. So it's not there. In patient with typical lesion, 1 topography. So if you get only 1 topography, you don't have dissemination space, then you can use this PRL for that. So if you get only 1 topography, and if you get paramagnetic lesion, you can use along with for dissemination space, and you can combine that with DIT or CSF. Same as 6 CVS. So only 1 topography, and you don't have dissemination in space, then you can either use these two, 6 CVS or paramagnetic lesion along with DIT or CSF. So you can use that to diagnose MS. So these are the various things. So they have increased the number of ways where you can diagnose the MS thing. So this is just a flow chart which they have given in this active. This was October 2024. Xavier Montbelt, and he is the leading the group for this diagnostic criteria change. He was the one who has proposed all these things, and he has given that in a talk here too. So signs symptoms suggestive of MS, no. So you only consider rule of better explanation. So if you get more than 2 topography or more than 12-month predation 2 spinal cord lesion, then DIS is there. So after that you require either CSF, CVS-6, maybe PRL, dissemination time or fold. So dissemination time is again 4 options. So if you get dissemination in space, 2 topography or progressive lesion with 2 spinal cord lesion, Then dissemination time માટેની જગ્યા you got 4 options. Dissemination time, CSF, central vein sign, or maybe lesions are present in 4 of 5 topography. એટલે DIT ની જગ્યાએ they have given various options. એટલે DIT એક as may not be required. So you don't waste time because જે પેલા આ બધા જે સ્ટડી હતા બેનિફિટ ઓરેકલ એ બધામાં they found that DIT takes time to develop 1 year, 2 year. So you may not waste the time. You want to start treatment early because MS is more aggressive early in the phase. Later on, after a few years, now many papers are coming up that after 4 phases the MS remains milder, then the disease may not be that aggressive. So in those patients, maybe even discontinuation of treatment has been now proposed with milder disease who are not don't have any symptoms for more than 5 years. So initial treatment is more important rather than late. So you have to start early. So if we want topography, that's only the no dissemination space also. Then CSF plus central venous sign, CSF plus parametric rim lesion. So dissemination time and CSF, so either CSF for dissemination time along with central venous sign or PRL. So only one topography you can diagnose. But in that you need to demonstrate both DIT or CSF plus CVS or PRL. So you can use that to demonstrate only with single lesion. So single topography lesion also you can diagnose MS. So lesion chromatography, MS will more than for CSF, CVS or dissemination time. So, and they have said that why this may be important because many times we see elderly patients, 50 years, vascular risk factors, or young patients with headache. You are not sure you are getting white matter lesions, whether it's MS or not. So in those patients, if you get a spinal cord, positive CSF or CVS6, so if you get one of the 3, then you can suspect MS. એટલે તમને વાસ્ક્યુલાઇટિસ કે પેલું you are suspecting white matter disease due to old age ના લીધે ડાયાબિટીસ એપ્લેક્સ છે young patient with headache છે ખાસ કરીને એવા સર્કસ you can use one of the 3 spinal cord lesion, positive CSF, or you can use central vein sign CLES6. So any one of the 3 can help you diagnose MS in those groups. That should be used. એ લોકો એવું propose કરે છે to prevent misdiagnosis. MS માં migraine માં થતા હતા એટલે કે તમે migraine માં હોય તો you should have one of these before starting treatment. ખાલી MRI પણ ના કરતા. So you should have one of these. પછી pediatric MS માં not to detail but they say mock should be done. જેમ adult માં આવું કીધું કે you require one of the these કે vascular risk factor હોય તો headache હોય તેમાં આ 3 માંથી એક લેવું એમ pediatric માં mock કરાવો. So they have not just make it simple, they have tried to make it more specific also. એટલે આ બે changes એવા છે they try to increase the specificity કે આ બે સબગ્રુપ જેમાં મિસડાયગ્નોસિસ વધારે થાય છે એમાં સ્પેસિફિટી ઇમ્પ્રૂવ કરવા માટે આ સજેશન આપ્યા છે. So what are the things? Many new things may come up કે VEP in OCT એટલે તમે OCT માં પ્રોગ્રેશન કરો કે OCT માં DIT ડેમોન્સ્ટ્રેટ કરી શકીએ કે નહીં. એટલે પ્રોસિડિયલ OCT થી આજે OCT કર્યું, ફોલોઅપ OCT કર્યું, એમાં તમે ડેમોન્સ્ટ્રેટ કરી શકો કે નહીં. જે અમારે તન્મય is going to do, right? OCT he is going to do OCT in the demyelinating disease એના માટે કરવાનું વિચારીએ છે. પછી use of parametric lesion in CVS. There are certain diseases, solitary sclerosis, એ હજી ડાયગ્નોસ કરવા અઘરા પડે. તમને ટ્યુબ ઇફેક્ટેડ demyelination ડાયગ્નોસ ના થાય, બાલોસેન્ટ્રિક સ્ક્લેરોસિસ હોય એ ડાયગ્નોસ કરવા અઘરા પડે. એના માટે આપણી પાસે કોઈ બીજા બાયોમાર્કર કે ક્રાઇટેરિયા નથી. તેમાં શું કરવું અને ડાયવર્સ પોપ્યુલેશનમાં બધું યુઝ કરવું છે, બીજા કોઈ બાયોમાર્કર છે કે નહીં. So these are the things. And એક રિક્વેસ્ટ હતી કે maybe next week we will have an ethics committee meet. SVP માં we have got a approval and we will get approval next week for ocrelizumab in RRMS patient. The criteria is simple: 2 attacks in 2 years or 1 attack in last 1 year, EDSS less than 5, patients will not get rituximab. Now કોઈ બી patient હોય and who wants to be ocrelizumab, the SVP માં સ્ટડી અમે સ્ટાર્ટ કરવાના છે. ઇનોવેટ ઓલ કે કોઈને બી પેશન્ટ રિફર કરવું હોય તો we'll take those patients. It's going to be biosimilar study. Sandoz company કરવાની છે. Original molecule versus biosimilar. It's no placebo arm. There is no placebo. Both the arm will get the molecule. So એટલે આપણે એટલી ઓછી છે, placebo નથી. So if you have RRS patients, you want to put on ocrelizumab, you want to give that try. The SVP will start.